So two things. Who's going into the lab today? Okay. I'm going to go up with you. I would like it if you could, whoever the last two people who are leaving, or actually, like, if you all kind of leave at the same time. There's a few bodies I'm going to want you to, like, maybe flip for me. You might not have to. I have to go up there, but I'm bringing in my neuroanatomy course on Wednesday in the morning, and I don't want to have to flip bodies because they don't do that for me. So whoever's going in there today, I'm going to leave a list. You just have to remember to do this, please, before you leave, to flip a couple bodies for me. That's all you're going to have to do, okay? And it could be that they're already in the right configuration, and this is a moot point. Second thing, I would like, you got a couple quizzes this week, so who's coming in at 1:30 Wednesday? Okay. What, only two of you? Okay, whoever the group is, I'd like us to plan to finish around 3:50, so like a little more than 2 hours. And then at 4, I'd like the second group to show up instead of 4:30, so just half hour earlier. And then we'll be done by 6:15, 6:30-ish, and that way you can get out a little earlier, okay? But that way we still have a good 2 hours, 15 minutes, which is fine. So there's a couple things we want to do in discussion lab, but mostly we want to be in cadaver lab anyways, okay? Cool? All right, so next, so three interesting things related to the tendon, the flexor digitorum longus. One, it's coming in at this oblique angle, which is problematic biomechanically. We kind of maybe solve that problem by adding this quadratus plantae muscle here. And when it contracts and shortens, it pulls this tendon in parallel with the long axis of the foot. That's all speculation as to whether that increases its whatever biomechanical efficiency. Next interesting thing is that there are these lumbrical muscles attached to this tendon. So that's just weird that you got a muscle coming off a tendon, not off a bone. Okay, same thing in the hand we're going to see. And in the hand also, we've got 4 lumbricals that we want to think about, okay? In the hand also, 2 nerves innervate the lumbricals. Okay, one of the differences in the hand, okay, the medial 2 lumbricals are innervated by the ulnar nerve, and the lateral 2 lumbricals are innervated by the median nerve. In the foot, the lateral 3 lumbricals are innervated by lateral plantar nerve, and 1 lumbrical is innervated by medial plantar nerve. Okay, so there's a slight difference, but in both cases, in the foot case and in the hand case, 2 nerves innervate the lumbricals. So these are really interesting muscles for a lot of reasons, for at least 3 reasons. One, in the hand and the foot, they come off the long flexor tendon, okay? 2, they can flex and they can extend, not at the same joint. So it's easy to demonstrate on a hand. So do you remember at the beginning of this lecture, we were talking about the metatarsophalangeal joint and how it has 2 axes. One axis does flexion, extension, high. The other axis does abduction, adduction. So this flexion at the metatarsal interphalangeal joint is thanks to the lumbricals, with help from some other things. But, okay, the other cool thing about the lumbricals is, so they're coming off tendons, and then distally, they're not going to bone. They're going to connective tissue. They're going to the extensor hood on top of your fingers and the extensor hood on top of your toes. So the attachments for the lumbricals are weird. And the extensor hoods are on the dorsal surface of the hand and the dorsal surface of the foot, not the surface of the foot. So if I could demonstrate, so you got these muscles that are starting on the plantar surface of the foot, this is your foot, and the tendons are going up to the dorsal surface of the foot. You see that attaching to the extensor hoods. And because of that, the lumbricals flex at this joint, but they're extending out here. Do you see how my fingers aren't flexed? They're extended. So the lumbricals flex, and they flex the metacarpal phalangeal joints or metatarsal phalangeal joints, and they extend the interphalangeal joints. All those reasons, it's interesting. Last thing that's really interesting about the lumbricals. You want to do this, so look at my fingers, they're flexed. I probably already asked you this, Megan. Okay. I want to extend them. Okay, doesn't it intuitively seem that the muscle that's going to cause the extension at the distal interphalangeal joint past tibia, the extensor surface of my forearm? I mean, it makes total sense. You got a fiber, you got a tendon coming down like this, all the way out here. If you pull on it, it's going to extend. No, it's not what's doing it. It's the lumbricals. Isn't that just crazy? Lumbricals on the plantar surface of the foot are doing that extension at the distal interphalangeal joint. Same in the hand. Crazy, but true. So I think that's 4 reasons the lumbricals are weird. Dually innervated, not attached to the bone, attaching to extensor hoods, able to extend far joints, even though the muscles are on the opposite side of the joint. Weird. Okay? So lumbricals, cool. So these 3 lumbricals innervated by lateral plantar nerve. This 1 lumbrical innervated by medial plantar nerve. Okay. So again, these 3 lumbricals innervated by lateral plantar nerve. The 1 lumbrical over here towards the big toe is innervated by the medial plantar nerve. 2 nerves takes to innervate the lumbricals. So these are going to flex metatarsal phalangeal joints, right? And they're going to extend the interphalangeal joints, in particular dip. Okay. Particularly the dip joint. Dip joint, they're going to extend. Dip joint, in particular, they're going to extend. Dip joint, in particular, extend. Like, how is that even possible? Because they're inserting into the extensor hoods. They're inserting into the extensor hoods. Okay? All right. So now, why did I put this in here? So, and I just updated this because I just think this Paralympics athlete from Iran, no, she's from India. She's so cool. But we'll get to that in a second. So, most of you, don't have a lot of dexterity linked to the intrinsic muscles of your foot. You're probably not eating food with your feet. You're probably not using your toes to paint. And part of that's because we grow up wearing shoes and we lose a lot of function. And if we didn't wear shoes, we actually would have more function. And part of it's just because shoes or not, we're bipedal and we tend to use our hands for manipulating tools. But with training, you can use your toes to do pretty cool things. So here's an archer using her toes to fire an arrow. Pretty crazy configuration there. But more relevant, so this is the woman who just won a medal at the Paralympics this year, who got a lot of press. I mean, like her first shot was a bullseye in the Paralympics this year, just using the toes of her feet. It's amazing. So you can develop more dexterity with the toes. And a lot of that dexterity that we associate with fine movement of the hand, and if you have it in the feet, that is due to the lumbricals and the interosseous muscles. And those are ones we're not really using much in the feet normally. So here's that quadratus plantae again. And you can see the lumbricals coming off its tendons. Four lumbricals coming off the tendons of flexor digitorum longus. If we then cut away those muscles, now you could say we're in the deepest layer of the sole, or you could say we're in the layer of the sole closest to the head. I don't know how you want to think about it, but or furthest away from the floor. You know what I mean? And so at this level, we have a couple flexors. We got little baby flexors, so we got a little dedicated flexor to toe 5. And we got a little dedicated flexor to toe 1. We have the same thing in the hand. And then we have a dedicated adductor, so it's going to pull the big toe back towards the other toes. Okay? So it's called an abductor. Adductor, because we're bringing it back towards the midline. I'm sorry, not abductor, adductor. If we're going back towards the midline, that's called adduction, right? So we have a dedicated adductor. We saw the abductors here, right? First layer, right? First layer, abductors. They're going to pull these toes away from the midline. But in the deepest layer, we have a dedicated abductor, and it has 2 heads. Same thing actually in the hand. So it's got a transverse head and an oblique head. Actually, also just like the hand, this is sort of interesting. Let me just kind of tie forward here. We haven't talked about nerves. So what's happening nerve-wise to the foot is we got some stuff coming in through the tarsal tunnel right over here, right? Tom, Dick, and very nervous Harry. The nervous part is the tibial nerve. It's coming down here through the tarsal tunnel, and what it divides into is a medial plantar nerve heading towards the big toe, and a lateral plantar nerve heading towards the little toe. Just like in the hand, it's this lateral nerve that innervates this adductor, which is counterintuitive. The adductor is moving the big toe. You'd think it would be the you'd think it would be the medial plantar nerve because the big toe is on the medial side. It's not. It's the lateral plantar nerve, okay? In the hand, hey, look at that. That's cool. I got time, people. Come on, I got time. We got all the time in the world. That's pretty good. Simple pleasure. Simple people. Okay, sorry. In the hand, we got a transverse and an oblique head. Guess what? Adductor pollicis muscle. That's not innervated by median nerve, which is what you think it would be innervated. It's innervated by the ulnar nerve. Actually, a branch of the ulnar nerve. So same exact thing in the hand. Okay? All right. Cool. So the adductor hallucis or hallucis is innervated by lateral plantar nerve, sort of counterintuitively. Okay. Actually, even closer to the head, finally, we get to the interosseous muscles, and they have this name because they're originating between the bones, between the metatarsal bones. You see them here. They're originating between the metatarsal bones. And there's 2 sets, one actually closer to the dorsal surface of the foot and one closer to the plantar surface of the foot. And our presenters are going to show you the ones closer to the dorsal surface. It's the same thing in the hand. They're easiest to see here on the dorsal hand, and they're harder to see here. But you look where you got to go to see these things. Like this is that fibularis longus tendon. See what I'm saying? So you got to go way in there. Okay. To see these guys. We teach a nice mnemonic. It works for the hand and the foot to remember what these dudes do. So the dab interosseous muscles are on the dorsal side of the foot, and they abduct. The pad guys are on the plantar surface of the foot, and they adduct. Let's go back again. At the beginning of the lecture, we talked about this joint, right, between the metatarsal bones and your phalanges. And that joint is biaxial. It allows for flexion, extension, abduction, adduction, flexion, lumbricals, abduction, adduction, interosseous muscles. The abductors of that group are on the dorsal side, and the adductors are on the plantar side, right? So pad and dab. These are I don't know what I was going to say. There's something. Okay, go to this table if you want a little more detail on attachments. Remember, the attachments for the lumbricals are pretty weird. Not bone to bone, tendon to extensor hood, right? So once again, first layer, plantar aponeurosis, okay? First layer of muscles above plantar aponeurosis, two abductors, an abductor to the fifth toe, an abductor to the first toe, and a short flexor to digits 2, 3, 4, 5. Second layer, quadratus plantae, flexor digitorum longus coming in. We can see the lumbricals coming off of it. Okay. Third layer, couple little mini flexors, a mini flexor to toe 5, and a mini flexor to toe 1, and then a dedicated adductor to toe 1. And that dedicated adductor has a transverse head and an oblique head. Lastly, we got a couple sets of interosseous guys that abduct and adduct the digits, and these two would be undeveloped in those of us who are wearing shoes all the time, and you can see them here. And the ones I'm going to ask you to see are on the dorsal surface. You're not going to see all of them. Okay, here you can see those extensor hoods, extensor hoodies, extensor hoodies. So just more examples of people who, for one reason or another, this individual either doesn't have arms or they are amputated, I don't know, and they have over time learned to develop great dexterity with the toes. So here's an individual who paints with his toes. Probably most of us here would have an incredibly difficult time doing that. He's using lumbricals and interosseous muscles in the way that we don't use them. And what I think is so cool, this is from Cell. Any of you who've been in other bio courses might know Cell is one of the premier scientific journals in the world, especially in biology. And this is an example of neuroplasticity, what they're showing here, which is like my favorite area of neuroscience. Neuroplasticity is that field of study which studies how the brain changes based on experience. And what they're showing, without belaboring this too much, is if you use your toes more, the brain will reorganize. What you maybe don't know, just a little tangent because this is so cool. Same for the hand. What you maybe don't know, like if this is a brain from the side, is it like the little strip of cortex right here, primary motor cortex, and a little strip of cortex right here, primary somatosensory cortex. And what's interesting about those two strips is there's a map of the body laid out there. And if you were to stimulate this part of motor cortex, you might generate a muscle in a little part of the body, right? And if you were to stimulate this part of somatosensory cortex in an awake patient, because neurosurgery is often done in an awake patient, the patient might tell you, oh, I just felt something in my shoulder, just felt something in my hand. You were just stimulating their brain. The really cool thing, though, is these maps of the brain are modifiable by experience. If you're a Braille reader and you're blind and you learn to read raised bumps on a piece of paper with the digits of your right hand, the left somatosensory cortex of your brain is going to expand. That part of the brain that's getting feedback from those two digits that you use to read Braille. How cool is that? This is a similar example. They're showing plastic changes in the brain in this individual who trained his toes to have high degrees of dexterity to paint. How cool is that, right? That the brain is modifiable by experience. One last example, sorry, we got a little bit of time. You all will do this. There's been a radical reconfiguration in how we teach people to recover from stroke. If you have a stroke where the upper limb is paralyzed, which is pretty common, let's take a really common stroke. Left hemispheric stroke, you end up with language issues, aphasia, right-sided paralysis. What they used to do in the old days, oh man, right-sided paralysis, you better just learn how to use your left arm. That's what we would do. It's not what you do anymore. You know what they do now? Which seems totally counterintuitive. You actually immobilize their good arm. So now they got, this is the good arm. They got a paralyzed right arm, and you're immobilizing the left arm. Like, that's the stupidest idea I've ever heard. No. You force them to use their paralyzed arm, and the brain will undergo, reorganization, plastic changes, and hopefully with enough physical therapy, they can regain some function in their good arm. If you didn't do that, which is what we told people to do 30 years ago, just use your left arm, you're not pushing the brain to reorganize plastic-wise, right? It was actually the worst thing we could have told patients to do. But now we're doing this new, updated, revamped approach, and I'm sure in PT school, when you learn that, stroke rehabilitation, you'll get into that. Pretty cool, right? Anyways, okay, moving on. This is the dorsum of the foot, and you can see these little extensor retinacula keeping these tendons nice and comfy and preventing bowstring. And I'm bringing this up because, one of the things we want to do is we want to follow the structures from the anterior compartment of leg and lateral compartment of leg down to the dorsum of the foot. Let's remind ourselves what was happening. Let's do it as a picture. Can I erase the little arch? So head of the fibula, okay, tibia. Okay, so, right here, common fibular nerve was appearing, and it was doing this. It was dividing into a superficial fibular nerve and a deep fibular nerve, and then this deep fibular nerve was joined by a couple of so important vessels. The anterior tibial artery, how did these guys get here? Okay, so now let's follow this stuff down across the ankle. So, kind of doing the rest of the lecture, part of it. So, whoa, watch out. Okay. So, superficial fibular nerve here is going to hit fibularis longus and fibularis brevis, but then it's going to go to the dorsum of the foot, and it's going to do cutaneous innervation. But let's make it black. Deep fibular nerve. Deep fibular nerve, actually. What was it doing here? Anterior compartment. When it gets down here, what it's going to do, it's going to do two things. It's going to hit a dedicated extensor muscle to the big toe, extensor hallucis brevis, it's gonna hit a dedicated extensor that's mostly to 2 to 4, extensor digitorum brevis. So those are intrinsic muscles of the dorsum of the foot. And it's gonna go down, this is kind of weird, and it's gonna provide sensation of the skin between toes 1 and 2. So that's kind of, okay? So we're gonna follow this stuff down. And then lastly, anterior tibial artery is gonna come down here, and it's gonna become dorsalis pedis artery, and we can take the pulse here. So like, I know it's not as done as much Western medicine, but Chinese medicine, you almost always take the pulse on both sides of the body, compare left and right. And sometimes, like if you suspect someone has peripheral arterial disease in Western medicine, they'll check both limbs. But if you wanted to do the pulse in the lower limb, this is where you could do it in dorsalis pedis artery. So it's anterior tibial artery after it crosses the ankle. It just changes its name. You know what I mean? So like this stuff, we got to follow down to the foot. Okay. Got to follow it down to the foot. So, here's dorsalis pedis artery, and here are these little intrinsic muscles I was talking about, starting to appear. Okay, and then like superficial fibular nerve would do this. It would kind of come down and branch like this to the top of the foot. Okay, so here's those 2 intrinsic muscles of the dorsum of the foot. Here's that little extensor lucis brevis. And then extensor digitorum brevis, mostly going to 2 to 4. That's good. And both of these, this is all deep fibular nerve territory. And then deep fibular nerve is going to become sensory to this region of toe 2 and this region of toe 1. Deep fibular nerve. Okay. Let's add on a little more things here. Sural nerve in the back of your calf comes over here to the side of the foot. Saphenous nerve starts over here on the medial side of the foot and goes up the medial side of the leg. Saphenous nerve. Just kind of like tying back to some other stuff. You know what I mean? Okay. See the extensor hoods for the lumbricals. Also, the interosseous muscles go into the extensor hood. So if this is an extensor hood, I like to call them the extensor hoodies. So we've got lumbricals going in here. And interosseous muscles. Okay. Just a little more detail if you want to read. I think I'll leave this up to your pathologist, but just know that there's different conditions that can result from, excessive flexion, in particular at this metatarsophalangeal joint, which is where we started this lecture. See that? Excessive flexion, pulling these proximal phalanges up. And then in hammer end plateaus, this middle phalanx is now getting pulled in the opposite direction. See it? Okay. And in hammer toes, actually, you get more flexion at this dip joint. See that? These can be caused by injury, things that are affecting the peripheral nerves. Like if your peripheral nerves die off, then some muscles are getting weak. And if there's an imbalance in different sets of muscles, right, that can cause maybe flexors to pull harder relative to extensors. You see what I'm saying? So different things can cause hammer toes or plateaus. I'll leave this up to your pathologist. Likewise here too. Where the toe 1 gets pulled towards the other toes. Remember, usually these are parallel, which is an adaptation for bipedal locomotion. But if toe 1 is getting pulled towards toe 2, in other words, it's getting adducted excessively, this condition. And again, multiple causes of this condition. I'll leave this up to your pathologist to get into this, but these can cause biomechanical issues, obviously things like that, pain. So look at that, this is normal. There's the adduction going on. Okay, so we're almost done, people. Thanks for your patience. We just got to do blood vessels and nerves, and I've kind of done a lot of the nervy stuff I wanted to do already. So here's that anterior tibial artery making its way down the front of the leg. We're crossing the ankle, and now we're going to change our name to dorsalis pedis. Pedis means foot. We can take the pulse there, and then we got a little, gives off a little guy that crosses the top of the foot. So it's called an arcuate artery. And then from that arcuate artery, there's little guys that dive down into the sole. So we have a way to connect the blood vessels on the top of our foot and the sole of the foot. Actually, same thing in the hand. So these are little interconnectors, and you can see them here. These are perforating branches. So it's like this. So anterior tibial artery becomes dorsalis pedis. It gives off this arching arcuate artery. And this guy gives off little perforating branches. Perforating branches to talk to the vessels in the sole of the foot. Lastly, we'll give off arteries that just travel down the long metatarsals. So these are metatarsal arteries. And then, like in the hand, you see how they bifurcate? So they bifurcate into digital arteries. Okay. So we can take the pulse down here. Yeah, you might do that if you suspect peripheral arterial disease, which results from plugging up the arteries with plaque, inflammatory processes, all kind of pretty complex, not pathological mechanism, but you can test for it. Major problem, right? Okay, what about the plantar side? Let's think again about what's going on in the tarsal tunnel. We're sending a vessel down through the tarsal tunnel. This was the posterior tibial artery, right? Okay. Deep to soleus. We're just exiting the tarsal tunnel. Now we're going to divide into a lateral plantar artery and a medial plantar artery. These are the guys I said, remember, it goes all the way back here. I said, hey, if you're dissecting and you see the plantar fascia, you got to be careful not to damage the medial plantar vessels and the lateral plantar vessels. So that's what we're looking at. And this lateral plantar vessel is actually going to arch across. So we have two arching vessels. On the top, right, we had this arcuate artery. See it? Coming off dorsalis pedis. And on the bottom, we got an arch. This is the plantar arch, deep plantar arch. Actually, in the hand, there's two arches too that we'll talk about, okay? So many similarities between hand and foot. And here you can see those little perforating branches that were coming from the dorsal side of the foot. You see it? So we're going to connect, that's where we're going to connect dorsal foot from plantar foot blood vessels. On this side, we have metatarsal arteries. So we got plantar metatarsal arteries. So like if you were to look at a foot, if you were to imagine a foot, a little toe as a sausage, you got dorsal metatarsal arteries and plantar metatarsal arteries, okay? Traveling along that little sausage, okay? And they kind of interconnect, all right. And you can see as you get out towards the phalanges, they bifurcate. Another view, this is a cool artistic rendition. So we just are leaving the tarsal tunnel here for the posterior tibial artery. We're going to divide into a lateral plantar nerve and a plantar artery. And we'll arch across, deep plantar arch, and we can connect up to the dorsal surface with these little perforating dudes. You see them? These little perforating guys. All right. So those perforating guys will connect. Okay. All right. So moral of the story is, as we're coming out of that tarsal tunnel, we got medial plantar artery, vein, and nerve, lateral plantar artery, vein, and nerve. Okay. Okay. And here you can see I just drew this little sausage, like metatarsal, dorsal metatarsal artery, plantar metatarsal artery. Okay. Last comment. This is kind of interesting. Same thing in the hand. I think it has to do. I'm not sure what the developmental reason for this is, but like in the hand, okay, there's a whole dorsal blood network, and so you think that would be the network surviving the tippy tips of your fingers where our fingernails are? No, actually, we rely on blood vessels from the palm to go up to the dorsal tips of our fingertips and our toes. So you can see that here. So the dorsal tips of our toes, they are not getting blood from this dorsal blood system. They're getting blood from the plantar system. See that branch going up there? Actually, the same thing for nerves. I do not know the explanation for this. It must have something to do with the little fingernails and toenails, but I don't know. It's interesting. Okay? So, like today in lab, Wednesday in lab, just make sure you can follow the femoral artery where it becomes popular to look for the 3 branches to the 3 compartments of the leg, and then look for the plantar vessels, and you know what I mean? You can handle it. Okay. Good news with respect to veins is the superficial veins don't have arterial counterparts, and there's only 3 I want you to know in the lower lip. I want you to know the dorsal venous plexus or network, which I ask you to look for at night in the shower. I want you to know the small saphenous vein that travels up the calf along with the sural nerve. And I want you to know the great saphenous vein that travels up the medial side of your lower limb that travels with saphenous nerve. Okay, that's it. Why am I ignoring deep veins? Because if you know the arteries of the body, you know the veins. Okay? The deep arteries of the body have veins that travel to the exact same place with the exact same name, except they're called veins. Okay? So if you know where the popliteal artery is, you know where the popliteal vein is. I'm not going to teach you to. If you know where the femoral artery is, you know where the femoral vein is. Done. So I'm just showing you superficial veins because there are no arterial counterparts. Okay. So deep veins follow the arteries. I'm going to say nothing about that because I just went over the arteries. Cool? Okay. So to end, let's just talk about nerves of the foot and then kind of proactively think ahead to the hand. Okay? Because eventually I want us to compare the upper limb to the lower limb. So we've been building this picture, and we're going to be able to see most of this. We're going to see medial plantar nerve here in purple. We're going to see lateral plantar nerve here in green. We're actually going to see on multiple cadavers the extension of deep fibular nerve that provides sensation right here in area 3 between toe 1 and 2. We're going to see that. You can see that in multiple cadavers. We're going to see on multiple cadavers where superficial fibular nerve pops out from the lateral compartment and goes to the top of the foot. We have that in multiple cadavers. We're going to see that. We have it on multiple cadavers, the sural nerve extending to the lateral aspect of the foot. You're going to see that. That's an extension of sural nerve. You could just call it sural nerve there for me. It is fine. All right? You're going to see all of that. Cool. You see all that? So, this is medial plantar nerve territory, lateral plantar nerve territory. Okay. So this is like an idealized view. This is what it looks like when these vessels come out of the tarsal tunnel, tibial nerve, right, in the tarsal tunnel. now divides, basically, like this is how, granular I get. I'm not sure what Ascendia would say, but like, it's basically I say, like, as soon as you get out of the top, right about there, okay? Because there's variation. It's going to divide into a medial, plantar nerve, lateral. Okay. Yay. Now, these guys then give off twigs that head up towards the toes, and look how they divide. When they divide, they're called common plantar nerves or common plantar tissue. A common vessel or common nerve is going to divide. So like at this dividing point, it's a common plantar nerve. See what I'm saying? Let me get rid of this. I'll show it to you again. So do you see this dividing point right here? That's a common plantar nerve. And then each of those, that where it divides, each of those guys is going on the side of that. It's going to go on the side of a digit. And those are called proper. Okay. Proper plantar digital vessels. Okay. You see the same thing in a hand. Okay. I'm going to let you work on the math here. I don't want to verbalize this, but like, if you had to guess, like, what are the muscles that the medial plantar nerve innervates the muscles related to the big toe? If you had to guess, what are the muscles innervated by plantar nerve? Lateral plantar nerve, everything else. So this medial plantar nerve, sort of big toe stuff. Of course, there's a big exception. Remember adductor hallucis? You'd think it would be innervated by medial, but it's actually innervated by lateral. Okay. I'm going to let you think about that. I want you to know that. Okay. I think we'll see most of this. There's even a cadaver where you can see some calcaneal branches. So like everything in here we should be able to see. Okay. Let's compare it now to like the hand. I think we're done basically. So in the hand, if we were to orient a hand so that digit 1 is in the same orientation as digit 1 on our foot, okay, the corresponding nerve to medial plantar nerve is also an M nerve. It's the median nerve. And the corresponding nerve to the lateral plantar nerve is the ulnar nerve. And look at this. Look at where the dividing line between those two is sensory-wise. In the hand, median nerve ends at digit 4, and ulnar nerve begins at digit 4. Another way to say that is digit 4 is dually innervated. Digit 5 is pure ulnar nerve. In fact, like neurologically, if you wanted to test, hey, does someone have an ulnar nerve lesion? You say, close your eyes. Can I touch your hand? You tell me if you feel this. If you feel that, then you know you have a good ulnar nerve, because that's the only nerve that goes to the pinky is ulnar. There is no overlap. You wouldn't want to do that test on 4 because it's dually innervated, right? Bad idea to test it there. Same exact thing on the foot. Medial plantar nerve ends at digit 4. Lateral plantar nerve begins at digit 4. If you wanted to test for lateral plantar nerve sensory function, you would do it on digit 5, you wouldn't do it on digit 4, okay? So pretty similar there. Both ulnar and lateral plantar hit the adductor hallucis or adductor pollicis, whether you're talking about hand or foot. So they're pretty similar, okay? These 3 lumbricals, once again, the lateral lumbricals, the lateral 3 lumbricals are innervated by lateral plantar nerve, and the medial 1 lumbrical is innervated by medial plantar nerve. So these lumbricals, that's how they're innervated. In the hand, it's different. These 2 lumbricals are median, and these 2 lumbricals are ulnar. Okay? Few differences. to end, we briefly talked about if you have a motor tract in the central nervous system, we call that an upper motor neuron tract, as opposed to like a spinal nerve, right? Sciatic nerve is a spinal nerve. This is a lower motor neuron system. Okay? So if you damage an upper motor neuron system, you're going to see increased reflexes, typically. If you damage a lower motor neuron system, you're going to see reduced reflexes. Another thing you see if you damage an upper motor neuron, and when you damage upper motor neurons, often follow with stroke. So we talked earlier about an example of a patient with right-sided paralysis and how now the typical treatment strategy is to actually immobilize their good arm and force them to use their paralyzed arm, okay? So that's often caused by a stroke. So another thing you see to end, I'm gonna finish early, people, even though it's 2 minutes early, okay? But another thing you see with stroke involving an upper motor neuron tract is the release of primitive reflexes. In a baby, if you were to stroke the sole of the foot, their toes might dorsiflex. If you were to do that in an adult, they would not. That reflex is suppressed. If you do this in an adult, you stroke the bottom of their foot in an adult who has an upper motor neuron pathology, their toes might dorsiflex like in a baby. That's called a Babinski reflex. But there's other reflexes that might appear, primitive reflexes like a sucking reflex, jaw jerk reflex, things like this that normally are repressed in the adult. Okay, so we're done. Cool. See some of you in lab upstairs. Otherwise, so if you're in, remember,